And thank you also for coming to this very early morning session. It is my goal for the next 45 minutes to give you an overview of the evidence and the practice of this cognitive behavioral analysis system psychotherapy. And if you want, you can follow along the slides by using that QR code that will take you to my ResearchGate page, where you can download the slides from today if you wish. And I would like to start by pointing out that CBASP is a bit of a funny name for the treatment. For one thing, CBASP is difficult to pronounce and to remember. And for another thing, CBASP is missing one letter that is very important, because CBASP is an interpersonal focused psychotherapy. So really what we're doing in CBASP is we're doing behavioral analysis of interpersonal contingencies. And the CBASP model is built on a clinical observation made by Jim McCullough, who has developed the CBASP model. And this clinical observation by Jim McCullough was that patients with chronic depression tend to behave in a submissive and hostile fashion. And I'm sure you can all understand that if you behave in this hostile and submissive fashion, it is difficult to make friends, to get close to others. It is difficult to get what you want in interpersonal situations. Now, the feeling of patients with chronic depression is, whatever I do, nothing will ever change that. And Jim McCullough termed this pre-operational thinking, and Hakan and Celine have done excellent research here in Turkey examining the underpinnings of this pre-operational thinking and how it relates to personality disorder. And so this is kind of the core assumption of the CBASP model that Hakan and Celine have examined. And another way of putting it is that patients with chronic depression, according to Professor McCullough's observation, they have difficulty understanding the effects they have on others. They feel nothing I do will ever change anything, and they overlook that their actual behaviors, their submissive and hostile behavior, does have effects on those they're interacting with. And what Jim McCullough is trying to do in his treatments is he's trying to empower these patients by showing them the effects they have on others, so they can make a choice. Do I want to cause what I'm currently causing in interactions, or do I want to cause something else? And what do I need to do to get from interpersonal interactions what I want to get? So as I said, the goal of this presentation is to broaden your understanding of this interpersonal model of treating chronic depression. And I will broadly cover these areas. I will define what we mean by chronic depression and then show a bit of evidence that there is such a thing as chronic depression. I will also show you evidence that this pre-operational thinking is specific to chronic depression in that it is not observed to this extent, or maybe not at all, in other mental disorders. And then I will try and show you how CBASP works, and also the evidence supporting the CBASP model in treatment. So I start out by talking about what chronic depression is. And you've already noticed that I mostly use the word chronic depression because the technical term, persistent depressive disorder, I think is a bit clunky. But when I use the word chronic depression, what I'm referring to is what DSM-5 defines as persistent depressive disorder. And Jim McCullough, the founder of CBASP, he was instrumental with his research in establishing this category in the DSM-5. And persistent depressive disorder is characterized by the duration of the depression. So a depression that is lasting 2 years or longer is called persistent depressive disorder. And this category is distinct from frequently recurring depression. So frequently recurring depression may or may not be a different beast, and we can get to that in the discussion section if you want, because we have done research where we divided patients into 3 groups. We had patients with episodic depression with few depressive episodes, and then with more than 5 depressive episodes, and with dysthymia in addition to their depressive episode. And what we have found that over the course of 2 years, those with frequent depressive episodes had the same course as those with dysthymia. So maybe if you look at the prospective validity of this chronic depression category, there might be some similarities between those who have chronic depression as defined by the DSM and those who have frequent depressive episodes. And chronic depression also needs to be differentiated from treatment-resistant depression, because some patients with chronic depression never have been treated. So there is an overlap between treatment-resistant depression and chronic depression, but it's not the same concept. And some people say that it's difficult to diagnose chronic depression. What I want to do next is show you an easy way to identify the subset of patients in your clinic that are suffering from chronic depression. These are the different causes of chronic depression that are defined in the DSM, and broadly speaking, you can differentiate between pure dysthymic disorder, where they have the depressive symptoms on more days than not in the past 2 years. And then there's the persistent depressive episode, where they have their depressive symptoms almost all the time, almost every day in the past 2 years. And then you have persistent depressive disorder with the recurrent depressive episodes, and that can come with or without a current depressive episode. Now, what I think is important to note on this slide is that the most common form of chronic depression is a persistent depressive episode. So most of our patients with chronic depression, they had their depressive symptoms for almost every day, almost all the time, for a period of 2 years or longer. And I'm sure many of you, and I include myself in that statement, have experienced days where you have a depressive syndrome, where you kind of, wake up a bit earlier, start ruminating, don't have as much pleasure in your activities, and so on and so forth. And now imagine having that for 2 years, and often much longer, every day, almost all the time. That is a severe mental disorder. It is not a mild disorder, as the ICD-10 makes us believe. This is a severe mental disorder, and I think it's very important for us to remember that. And as I said, it's easy to diagnose. It's easy to select from your patient sample those who have this chronic depression. And what we've done here is we developed a very simple screening question. We have given our patients a self-rating form for depressive symptoms. We use the quiz. And then after giving them the quiz, we asked them one simple question. We asked them, what we've just asked you about are depressive symptoms. And what we'd like to know next is, when was the last time in your life when you were more or less free of these depressive symptoms for 2 months or longer? So technically speaking, we were asking them when they last met criteria for remission. And what we're looking for, if they met criteria for remission within the past 2 years. And if in this screening they say that they have not met criteria for remission within the past 2 years, then they're likely to have a chronic depression. So this screening is very sensitive, but it's not very specific. So you have to go on and do a clinical interview. After that, I'm going to show you how you can quickly do this clinical interview. I just want to mention briefly that this persistent depression screener has been translated into Egyptian, and Mohammed El-Sheikh, who was here yesterday with us, he used it in his Egyptian population and pretty much found the same values for sensitivity and specificity in his sample. Now, what can you do clinically when you suspect that someone has a chronic depression? And what I would suggest you do is you start, as you always start, you assess the current depressive syndrome and assess whether or not they currently meet criteria for a depressive episode. And after that, you ask that question. You ask them, when was the last time you were more or less free of depressive symptoms? So you ask for the remission criterion. And if they say that that is more than 2 years ago, you ask them, well, in the past 2 years, roughly speaking, did you have more or less than, I'll start that sentence again. Did you have more days than not with depressive symptoms, or was it less than half of the days in the past 2 years with depressive symptoms? So you kind of try and make sure you're really looking at least dysthymia. And then with these two questions, you really efficiently identify your chronic depressive patients. Then you can go on to asking them about the cause of their depression. You ask them, when was the first time you had a depression in your life? Was it before or after 21 years of age? Because you want to know if they have what DSM calls early onset. And then with your fifth question, you want to determine how many depressive episodes they had in their life. So you ask them, how many times in your life did you have periods of 2 weeks or longer when you had depressive symptoms for almost every day, almost all the time? So with these 5 easy questions, you can easily identify and characterize your patients with chronic depression. You ask for the depressive syndrome, you ask when they last met criteria for remission, you double check whether in the past 2 years they have at least met criteria for dysthymia, you ask for the age of onset, and you ask for the number of depressive episodes. Now, the next chapter will cover the question of whether chronic depression really is a distinct group of patients with distinct characteristics. And I am following the framework here of antecedent, concurrent, and predictive validators of diagnoses. And I'll start with the predictive validators. If you follow a patient who at baseline meet criteria for dysthymia for 10 years, almost all of them will meet criteria for a major depressive episode over these 2 years, which again reminds us that chronic depression is not a mild disorder. And then if you follow these patients over 2 years, you will also notice that they spend more time in depression than those with episodic depression. So it is a distinct category. If you look at antecedent validators, so you can also kind of see that as etiological factors in your chronic depression, you will find that patients with chronic depression are distinct from patients in episodic depression in that they more often report childhood emotional abuse and other childhood adversity in their history. And I will focus a bit more now on the social cognitive deficits that distinguish patients with chronic depression from those with episodic depression. And I will get back to the pre-operational thinking that we talked about earlier shortly. But before I do that, I want to show you this slide, which shows that patients with chronic depression also have a distinct interpersonal style that I mentioned earlier. So what you probably experience in your clinical practice, that these patients are submissive and hostile, is also something that can be shown empirically using the so-called interpersonal message inventory. And our current president of the International CBASP Society, Massimo Tarzia, he has conducted a meta-analysis of all the studies that looked at the question whether or not patients with chronic depression are distinct in their interpersonal styles from patients with episodic depression healthy controls, and he confirmed this characteristic interpersonal style in chronic depression. So you could start by saying that the target of the CBASP model is this characteristic interpersonal style, and what I would like to move on to now is what we believe causes this interpersonal style. And I will use a simple clinical example to illustrate that. Imagine you're treating a patient we'll call Mr. Miller. And imagine you're treating him, and I suppose, like most therapists, you're kind and you're understanding if Mr. Miller has difficulties and supportive with those difficulties. And in this therapeutic style, you have talked about some behavior change with Mr. Miller. And then in the next session, you greet him and you ask him, Mr. Miller, I would like to know what it was like trying out this behavior change. And you ask that in your friendly, supportive, and understanding style. And he say, I haven't tried it, it's not going to work anyway. And you want to know, how come that Mr. Miller responds to your friendly, supportive, and understanding style in this hostile fashion? And I'll walk you through this slide because it might help us understand that. And what you can see on this slide is this is the so to speak, the inner working of Mr. Miller, how he perceives the world cognitively and emotionally, and how these cognitions and emotions drive his behavior. And this is you, this is the interpersonal environment of Mr. Miller. And the theory is that these characteristics of you, that you're friendly, understanding, and helpful, these characteristics, they bounce off a wall that Mr. Miller has built around himself. And he has built this wall around himself because with his significant others, he has experienced emotional abuse. So he kind of has built this wall around himself to protect himself from this emotional abuse. And he'll think, well, if I tell my therapist that I tried what we talked about last week, but then I encountered obstacles and I lost hope and I stopped trying, if I tell this to my therapist, he will get mad at me like my father always had. He'll tell me I'm no good, I don't amount to anything, and if you understand these cognitions, you also understand better why he behaves the way he does. You know, why he says, I didn't try, it's not going to work anyway. In other words, he is responding to the hurt from his history and not so much to the possibilities that he has with you in the present. And Jim McCullough labeled this perceptual disconnection. And the trouble with this perceptual disconnection is that this behavior, if he's not only showing that with you, but also in his everyday life, he will pull for hostility in his everyday interactions. If he is behaving to friendly interaction partners in the hostile pattern, they will not remain friendly, they will start becoming hostile. Now, how does Mr. Miller process this hostility in his everyday life? He'll think, it doesn't matter what I do, because whatever I do, nothing will ever change. And what he overlooks is that it is these specific behaviors that he shows that are pulling for the hostile response in his environment. So this perceptual disconnection really plays out in two ways. For one thing, he overlooks the possibilities he has with you in the present, and then also he overlooks the the impact of his behavior on his interaction partners in his everyday life. And as I said, we have put the theory to the test step by step. And the first thing is we have looked if this pre-operational thinking can actually be demonstrated. And a colleague of mine in Lübeck, Tanja Kühnen, she has developed a questionnaire that measures this pre-operational thinking. And it's a very simple questionnaire. Participants in the questionnaire, they get 20 items. And these 20 items are interpersonal situations. And the respondents are asked to say how they would respond in this given situation. And they're giving two response options. One is a pre-operational option and one is a formal operational option. So one is whatever I do, nothing will ever change, and the other is what do I need to do in this situation to solve this problem. And you can see an example here that a boss is talking to this person, and he's saying that he's generally satisfied with his work, but he has noticed that he had made more mistakes lately. And now the participant is being asked how he would respond in that situation. And there's two options. One option is, whatever I tell my boss, he will never appreciate what I do. Or you could say to him, there have been problems and I have to explain to my boss why. So one is pre-operational and the other the formal operational answer. And whenever respondents give a formal operational answer, they get a point. So the lower the score on this questionnaire, the higher the level of pre-operational thinking. And what we have found is that patients with chronic depression score significantly lower than patients with episodic depression and healthy controls on this questionnaire. So it does seem that this pre-operational thinking really does distinguish patients with chronic depression from patients with episodic depression. And after we have done that, we kind of put the entire model to a systematic test. What I have showed you earlier is that the CBASP model works on the assumption that adverse childhood experiences lead to an anxious, avoidant style in interpersonal interactions, which in turn leads to pre-operational thinking, which in turn leads to this hostile, submissive interpersonal behavior, and that in turn leads to chronic depression. And you really have to trust me, I suppose, on that we have examined every single error in this slide. Because I probably don't have time to go into every single of these errors. What I would like to point out is that we have also looked at the question if this pre-operational thinking is also present in other mental disorders beyond episodic depression. And we have collected a sample of patients with panic disorder and a sample of patients with chronic pain disorder. And again, we have given them the childhood trauma questionnaire to assess their adverse childhood experiences. And I'm sorry, the monitor isn't working anymore here. Okay. We have given them the childhood trauma questionnaire to assess for adverse childhood experiences. We have given them the interpersonal message inventory to assess the interpersonal style, and again we have given them the Lübeck questionnaire of pre-operational thinking to assess the pre-operational thinking style. And in summary, what we have found is that our sample of patients with chronic pain and our sample of patients with panic disorder, they also reported emotional abuse. They were also judged by their significant others to be more hostile, submissive, but they didn't have the pre-operational thinking. And this finding speaks to the specificity of the CBASP model, that this pre-operational thinking might be something that we predominantly find in chronic depression, and it might not be present in other patients who we also experience to be withdrawn and hostile in their interactions. So we have to look with each and every patient whether really this pre-operational thinking style, whatever I do, nothing will ever change, underpins this interpersonal style. So I hope I have convinced you that this perceptual disconnection contributes to the maintenance of chronic depression, and I hope that I've also convinced you that this perceptual disconnection is specific to chronic depression. And what I would like to turn now to is a treatment for chronic depression. And what I'm presenting to you here is the summary of the guidelines of the European Psychiatric Association for Chronic Depression. They have very systematically examined the evidence for the treatment of chronic depression, and they have come to the conclusion that based on the evidence, CBASP is the first-line treatment for chronic depression. And that was a large panel from the European Psychiatric Association with a broad range of CBT therapists, but also psychodynamic therapists, and together, based on the evidence, they came to this conclusion. Now, if you look at the national guidelines, CBASP is mentioned but not necessarily recommended in the British, Canadian, Danish, Dutch, and German treatment guidelines. So they have come to similar but not entirely matching conclusions. And I have spent so much time elaborating on the model because the model, as I said, underpins this treatment. And all the techniques in CBASP are geared towards overcoming this perceptual disconnection, are geared towards helping the patient understand the effect that their behavior has on others, so they can make a conscious choice. Do I want to cause what I'm currently causing, or do I want to cause something else? And what do I need to do to achieve what I want in interpersonal situations? And broadly speaking, you can divide the techniques in the CBASP model into techniques focused on the therapeutic relationship, and that's called disciplined personal involvement. And then there's one technique that is aimed at interpersonal relationship in the everyday life of these patients. And you start the treatment by trying to understand the interpersonal expectancies that these patients bring into treatment with you. So you try and understand how what they have experienced with their significant others influences how they see interpersonal situations. You try and understand how what they have experienced with significant others has led to problems in certain interpersonal domains that we call emotional hotspots. And these emotional hotspots, according to the CBASP theory, are intimacy, closeness, disclosing needs, making mistakes, and expressing anger. And based on the significant other history list, you try to identify for each and every patient what is the emotional hotspot for him or her. So if we go back to Mr. Miller, maybe he has not only experience with his father that when he was making mistakes he was punished, but he has a very pervasive experience of punishment around making mistakes. Maybe he has experienced that for a long time in his life, not only with his father, but also with other people, both inside the family and outside the family. And maybe this has led to an expectancy that if he makes mistakes around others, he will be hurt. And that's what we call in CBASP the transference hypothesis. We try to summarize the interpersonal expectancy based on a thorough history of the significant others. And after that, we spend most of the treatment doing what we call situation analysis. So we ask patients to bring in prepared what we call coping survey questionnaires, so where they prepare the situation analysis, and then we do them with patients. And I'll briefly mention one example with Mr. Miller, where he brought in an interpersonal situation with his wife, where his wife asked him, well, what do you want to eat for dinner tonight? And he said, oh, I don't know. And that's the first step in the situation analysis. You ask your patient for a description of the situation from an observer's point of view. And then you tap into his interpretations. You try and find out why he behaves in the situation the way he does. And the interpretation that Mr. Miller had in this situation was, well, she doesn't appreciate what I want anyway. And then in the next step in situation analysis, you go back to an observation of the patient's behavior. And this time you focus more on the nonverbal behavior. So you focus with Mr. Miller that he probably stood there with his arms crossed, avoiding eye contact, and had a rather harsh voice. And then you focus on the actual outcome, to what actual outcome this behavior led in this situation. Namely, he said, oh, I don't know, and left the situation. And then you start thinking about Mr. Miller, what his desired outcome would be for this situation. And then you start what we call a revision phase, where you go back to the interpretations and look at how these interpretations might have been an obstacle for him in reaching this desired outcome. And we also look at how these obstacles can be overcome, how these interpretations can be dealt with in the way that they lose their impact on Mr. Miller's behavior. And then we summarize what Mr. Miller learned in this situation and apply it to other situations, and also do role plays to teach him skills of how to apply this new behavior. That's really the core technique of CBASP. And one of the presentations in our symposium yesterday showed us that it's probably one of the aspects of the model that makes CBASP so effective. But we also have other techniques in the therapeutic relationship. And one is what we call the interpersonal discrimination exercise. And the goal of the interpersonal discrimination exercise is to establish interpersonal safety in the therapeutic relationship. To establish interpersonal safety by helping Mr. Miller see that he is not hurt in the therapeutic relationship with you as he has been hurt by significant others. For instance, one session, Mr. Miller came in and he was visibly upset. And I said to him, well, Mr. Miller, welcome, and I'm glad you're here. And he said, well, you'll soon find out that I better had not come today. And he kind of, verbally punished himself. He verbally punished himself because he had forgotten to bring his situation analysis. And so in CBASP parlance, the emotional hotspot was activated. He made a mistake and he was afraid to be punished by me, the therapist. And what you do in interpersonal discrimination exercise, you first of all pinpoint this hotspot and then ask, how would his father have reacted had he made a mistake like that, had he forgotten something important? And then you move on to asking him, how have I just reacted? What similarities and differences do you see between how your father has reacted and how I have just reacted? And what does it mean for our therapeutic relationship now that you see that I'm reacting differently in the situation than your father? And what will happen through repeated application of this interpersonal discrimination exercise, that Mr. Miller will feel safer and safer in the course of treatment with you, also around making mistakes. Now, the last element is what Jim McCullough called contingent personal responsivity. And contingent personal responsivity involves highlighting behaviors that the patient shows within the session, and then also highlighting the effect that this behavior has on you, the therapist, in the moment in the session. So for instance, if Mr. Miller behaves in this hostile fashion to you by saying, I didn't try, it's not going to work anyway, you will highlight that behavior and ask him, Mr. Miller, what do you think my reaction is if you respond to my friendly question in this hostile manner? And that will give Mr. Miller an opportunity to think also in the therapeutic relationship with you about the question, do I want to cause what I'm currently causing? Or do I want to cause something else? And what do I need to do to get what I want from my therapist? Now, there is evidence supporting the effectiveness of this model, and this slide summarizes the evidence. We know that CBASP is more effective than non-specific psychotherapy for depression, namely supportive psychotherapy, and what we used in that study is a Rogerian type of talk therapy. We also know that combination of CBASP with antidepressant medication is more effective than CBASP alone, but only if patients also want to take medication. And CBASP has also been compared to other depression-specific psychotherapies in a number of randomized controlled trials, and we have done an observational trial that I reported yesterday. We have also compared CBASP with MCT, which Hakan mentioned earlier today. And to summarize these findings, I would say that the jury is still out whether or not CBASP is more effective than other depression-specific psychotherapies. There is clear indications that it might be. CBASP is more effective in a group format than mindfulness-based cognitive therapy. It is more effective in individual therapy than interpersonal psychotherapy. It is more effective than treatment as usual in the Netherlands. That was a study conducted by Jenneke Wiersma. And patients in her comparison group, they had either CBT, psychodynamic psychotherapy, or interpersonal psychotherapy, and CBASP was more effective. In our observational study that I'll get back to in a moment, CBASP was as effective as metacognitive therapy, at least in the short term. I'll talk about the long term in a moment. But there's also a study conducted by Winfried Rief in Marburg, Germany, where he compared CBASP to cognitive behavioral therapy. And in his trial, cognitive behavioral therapy was superior to CBASP. And we don't have randomized trials in inpatient and day patient settings yet, but data from observational trials point to the effectiveness of CBASP also in these settings. And if you're interested, you can find a summary of all these trials with effect sizes and response rates in this table, but I'm not going to go into the details of this table. You can, again, download it through that QR code, and you have all the data you need. What I would like to focus on for the moment is the trial that I already mentioned, where CBASP was compared to supportive psychotherapy. This trial was conducted by Elisabeth Schramm from Freiburg University in Germany, and we were a center in that study. And the main finding of that study was that at the main outcome time point in 20 weeks, CBASP was more effective than supportive psychotherapy, with a number needed to treat of 6. So that means that you need to treat 6 patients with CBASP compared to supportive psychotherapy for 1 additional patient to benefit. So that means the other 5 patients would have also benefited from supportive psychotherapy, or would have benefited irrespective of therapy, or not benefited irrespective of therapy. And 1 additional patient benefits if you treat them with CBASP. And number to treat for 6 sounds small, but if you look at the larger literature, it's actually quite a good effect size. And what I want to show you now is if you carefully select your patients you're treating with CBASP, then you can get even higher effect sizes. These are the results of a dissertation project of one of my doctoral students, Nela Asman. And she has found that in patients who report early emotional abuse and in patients who have comorbid social anxiety disorder, you have an even higher effect size with a number needed to treat of 2 or 3 if you compare CBASP to supportive psychotherapy. And this really nicely fits the CBASP model, because the CBASP model says is that what we're treating with CBASP is interpersonal difficulties that are due to anxious avoidance in social situations that is developing against the background of early childhood diversity. So these moderator analyses, I think, nicely show that for this subset of patients that the model was developed for, it is also most effective. And what we have also looked at in this study, if the change model of CBASP can be supported with data. So we have done a serial mediation analysis, and we looked at the question whether if it is the therapeutic relationship that leads to a reduction in this submissive interpersonal behavior, and if that in turn leads to an improvement in depressive symptoms. And what you see here is the direct effect. I already told you that. Compared to supportive psychotherapy, CBASP is more effective in reducing depressive symptoms. And compared to supportive psychotherapy, patients treated with CBASP also report a higher therapeutic alliance early in treatment. And if they report a better therapeutic alliance early in treatment, they have a greater reduction in their hostile submissive behavior later in treatment. And if they have this greater reduction in their hostile submissive behavior, they also have a greater reduction in the depressive symptoms. The serial mediation analysis, I think, supports the CBASP change model. And I've already told you about our observational study in the day patient clinic, and we have talked about the results yesterday in this symposium. I'll just briefly summarize. What we found in this observational study is that patients treated with CBASP improved as well as those treated with MCT in the short term, but in the long term, you see that in this slide, these are the follow-up data. On the left side, you see those treated with MCT. On the right side, those treated with CBASP. And you see in the long term, those treated with MCT did not improve further. Some of them even deteriorated. And in those treated with CBASP, they further improved in the follow-up period. And they improved particularly if they experienced few negative effects. So we have seen an influence of negative effects during the treatment on the long-term outcome, but only for those treated with CBASP. And also at this conference, Lea Schumacher, who's also in the audience here today, she has presented results on another change theory that we have examined using the CBASP versus supportive psychotherapy data set, and that is the network change theory. So up till now, I have told you that we need to change pre-operational thinking to change the depressive syndrome. Now, I now invite you to look at this again from the network theory perspective. And the network theory perspective assumes that symptoms are not passive indicators of something else that's wrong, but rather symptoms are active ingredients in maintaining the disorder. And one example would be if you imagine again you're waking up early in the morning and ruminating and then feel anhedonia, you can make a decision whether or not to get up in the morning. And if you don't get up, you might have feelings of guilt in the course of the day because you missed things that are important to you, and so on and so forth. So maybe what maintains depression is how these symptoms interact, how strongly the symptoms interact. And Lea has put this hypothesis to the test, and she has found in her analyses support for the changed theory that would for the changed theory that would result from this network theory, namely that if this theory is correct, then the treatment that is more effective, in this case CBASP, would lead to a reduction in the strength of association between these symptoms over time. And she has found exactly that. And I give you one example down here. In the course of treatment, the strength of connection between psychomotor problems and suicidal ideation decreased for those treated with CBASP and increased for those treated with supportive psychotherapy. So I now come to the summary. So we also have a few time for questions. I hope I have succeeded in showing you that persistent depressive disorder, also called chronic depression, is diagnosed if your depression is present for more than 2 years, and that you can easily screen for chronic depression. I hope I have showed you that chronic depression is characterized by childhood adversity, which in turn leads to pre-operational thinking, which in turn leads to an interpersonal style that is characterized by a hostile and submissive behavior. We have talked about the fact that CBASP, according to the guidelines by the European Psychiatric Association, is a first-line treatment for chronic depression, and it targets these specific deficits of chronic depression, namely early adversity leading to deficits in social cognition and interpersonal behavior. And it actually works best for patients who have experienced early adversity and who have interpersonal avoidance, who have anxious avoidance in interpersonal situations. And I have shown you that the effects of CBASP can be explained by CBASP change theory, but also be explained by network theory. And I thank you kindly for your attention, and I thank my collaborators for their effort in putting together all these results.
Thank you very much.